Good evening, everyone present here. I am Faraz from IJCP Group. I welcome all the participant doctors on today's session. Let's welcome today's speaker with great honor, none other than Dr. Ratan Jha sir. Sir is a senior nephrologist and transplant physician at Care Hospital Outpatient Center, Banjara Hills, Hyderabad. Today, sir is going to discuss on a topic drugs and kidney interaction and associated disorder. Let me tell you overview of the topic. Drug-induced renal disorder refer to kidney damage or dysfunction caused by certain medication. These disorders can range from mild changes in renal function to severe renal failure. Identifying and managing the drugs-induced renal or disorder is paramount to prevent further kidney damage and preserve renal function. To know more about this topic, I would like to invite sir and hand over this session to sir. Over to you, sir. Kindly proceed from here.
Uh, Good evening, friends. It's a proud privilege for me to talk about a common topic which will be of interest to all the internist, physician, and the specialist, including nephrologist, the drugs, and the kidney. Its interaction, how does it ultimately has a kind of deleterious consequences in case it is not realized early. When we talk about drugs and kidney, there are various ways the drugs can affect kidney and the vice versa. The drugs which affects kidney in any way which is detrimental is referred to as drug-induced kidney disease or as an abbreviated form of DIKD, where the effect of the drug could be a direct effect, could be because of the dose error the effects are happening, that is we are giving a kind of higher dose than it is recommended because of the drug interactions where the drug becomes more detrimental, or could be an allergic response. So the DIKD, that is a drug induced kidney disease, is because of any of these factors, which could be direct, indirect, due to interactions or due to an allergic or idiosyncratic phenomenon. Kidney, on the other hand, affects the drug disposal. That is because of which there could be an adverse drug reaction in case we are not trying to take care of the drug pharmacology in mind when prescribing a drug, and because of that consequence, we have an extrarenal kind of effect that is beyond the kidneys. For example, hypoglycemia because of unmodified doses of antidiabetic drugs, somnolence because of the drugs which act on the CNS system, which may have a prolonged effect because of reduced excretion of the metabolites, ototoxicity because of aminoglycosides, bone marrow effect because of prolonged drug exposure due to certain drugs which are used in not only in cancer chemotherapy or in transplant, but even in patient of chronic kidney disease. So this may be the two ways the kidney and drugs interact. One is the drug affecting the kidney, and other is the kidney affecting the drug disposal, leading to an extrarenal manifestation, which has to be appreciated and understood. Any drug which has an excretion of more than 30% from the kidney will require a dose adjustment when the kidney function is has declined. So when we talk about drug and kidney disease, the first thing that comes into our mind is drug nephrotoxicity, which is because of the following things, like the change in the kidney structure or the function, which could be a kind of organic or kind of histological injury, which could be acute or chronic, which may reverse or may become irreversible. And this usually occurs after exposure to drug for a reasonable length of time. That it is said that minimum 24 to 48 hours is required to get a drug nephrotoxicity, and in absence of that kind of duration, the linkage cannot be said with certainty. The drug nephrotoxicity causing AKI, CKD is shown in the slide. There is a common kind of occurrence. 10 to 20% of patients who develop an acute kidney injury, defined as a rise in serum creatinine by at least zero point 0.5 milligram or a rise in the creatinine from the baseline by 50%, is seen in 10 to 20% of patients prescribed the drugs. 5 to 10% of patients who have developed chronic kidney disease are linked to drug nephrotoxicity. And 25% of AKI, particularly in ICU setting, is attributable to drugs. That is to say that drug nephrotoxicity is not a uncommon thing, and one has to understand it well to prevent this untoward side effect. The importance of this, therefore, this topic is that we need to recognize the problem, which is often reversible on discontinuation of the offending drug. It may lead to an acute kidney injury, which may even require dialysis, or can lead to a kind of subacute injury, which slowly progresses over time to chronic kidney disease and may require dialysis on the long term. For example, the analgesic abuse nephropathy. Why is kidney vulnerable to toxic insult is shown in the slide that the kidney receives close to 20 to 25% of cardiac output per minute. That is, in almost close in 5 minutes time, the whole blood circulates through the kidney, and because of this increased blood supply, because of the large surface area to which the blood is getting exposed, because of the high concentrating capacity of the tubules and the inner medulla, which is almost at the verge of hypoxia, any kind of drug insult in combination with hypoxia could lead to a kidney injury. So in this cartoon, what is shown in the slide is that the lower part of the tubules, that the inner medulla, is having a kind of concentration gradient which is quite high, and this is the point where the maximum kind of ischemic injury happens. Medullary thick ascending limb of loop of Henle is the area of the tubule which is in the outer medulla, but it has got a very high transport capacity, which leads to a kind of exhaustion of the oxygen that is available in the medullary interstitium, leading to a hypoxic injury. So, of the whole tubule, the commonest kind of injury that we see is in this part of the tubule, that is thick ascending limb of loop of Henle, including the loop of Henle in the medulla. So that is the histological concept and the basis why the kidney gets affected. That is because of increased blood flow repeatedly and because of the hypoxic situation which is prevalent in the medulla. Drug-induced kidney disease is classified pharmacologically as well as pathologically, which is from the slide. The pharmacological classification of DIKD is type A type of drug-induced kidney disease, which is dose-related. That is, the higher the dose, the higher is the risk of toxicity, and which can be reduced if the dose is reduced or withdrawn. And such type of injury, if has not gone beyond the stage 2, recovers completely. Type B type of drug-induced kidney injury is considered to be idiosyncratic drug injury, where the full recovery may or may not happen. That is to say that these type of type B type of DIKD are not seen in most of the patients. It is seen in select few, and it may have a genetic basis or idiosyncratic basis because of some allergic response to the incipient that is there, which cannot be predicted. Pathologically or phenotypes of DIKD is pathologically classified as a tubular injury or tubular interstitial injury presenting as TIL, glomerular injury, that is the capillary loop suffering from injury, which can present with various forms of manifestation, including nephrotic syndrome and renal dysfunction. Vascular injury in the form of uh, either vasculitis or TTP type of injury, or an obstructive injury in the tubules in the form of crystalluria or stone formation. So these are the pathological phenotypes which could be linked to either type A type of DIKD or type B type of DIKD. And based on the pathological phenotype, the outcome could be different. So this is a slide to show that what are the types of drugs which can lead to a kind of kidney injury in different settings. There are certain drugs which are producing a kind of pre-renal azotemia, that is when like an antihypertensive agent or diuretics, when the blood pressure gets reduced, the creatinine can go up. There are certain drugs which are acting at the postrenal status, that is, it is producing a kind of obstruction because of crystalluria or because of the papillary necrosis that is usually linked to NSAID on many kinds of compounds, analgesic, multiple analgesic together, or because of urinary retention drugs like anticholinergic drugs, which can lead to a kind of retention of urine with a renal dysfunction, or tricyclic antidepressant, which has a similar kind of anticholinergic property. So this concept of drug toxicity could be looked at pre-renal factors, which is reducing the kind of perfusion to the kidney, or post-renal factors. And once these factors are excluded, then the factors which are operative usually are at the level of the parenchyma, the small vessel disease like the hemodynamic injury because of NSAIDs, or glomerular disease which can present with a kind of glomerular injury as RPGN, particularly linked with drugs like hadalazine, which is a common drug which is prescribed in the cardiac setting or for blood pressure, or other drugs which are listed in the slide are not that common. Acute tubular necrosis is the commonest phenotype of drug-induced injury, which could be linked to aminoglycoside, cisplatin, ifosfamide, which are the common drugs which are used in the setting of malignancies. Acute intestinal nephritis is the commonest kind of histological phenotype which will be seen in patients who are having a kind of idiosyncratic type B kind of DIKD, that is idiosyncratic or allergic response, which could be seen with all kinds of drugs which are prescribed. But there are certain drugs which are common, which are listed in the slide. And intertubular obstruction, which is a kind of crystalluria, which because of certain drugs like acyclovir is a common drug, or drugs which are used for treating HIV like indinavir, which can produce a kind of DIKD. So this is a conceptual framework to understand that when you're talking about drug toxicity, the things could be working at different levels. One of the ways a small vessel disease could manifest is thrombotic microangiopathy, which is commonly seen with drugs like cyclosporine tacrolimus or cancer therapy drugs like mitomycin C and many other kinds of cancer therapies. So when we prescribe a drug, we need to be familiar with what are the possibilities which can happen in case the kidney dysfunction is noted. So the mechanism of drug-induced nephrotoxicity is, for simplicity's sake, is shown in the slide that it can be because of change in the glomerular hemodynamics. That is, when you're using NSAID for pain or ACE inhibitor or ARB for treating hypertension or proteinuria, it can lead to a kind of rise in urea and creatinine because of change in the glomerular hemodynamics. And if it is well picked up, it is reversible. The other way the mechanism can manifest as kidney dysfunction is tubular toxicity or ATN, which could be because of aminoglycoside, commonly used drugs, IVIG, or even amphotericin that is used in setting of fungal infection. The third type of nephrotoxicity is a kind of allergic response or acute interstitial tubular nephritis, and it could be because of many drugs. The common drugs are listed like rifampicin, antibiotics, even diuretics are mentioned as a common cause of allergic inflammation with AKI. Crystal induced nephropathy is a kind of special category of AKI which can happen with the drugs that associated with acyclovir, cotrimoxazole, and sometimes because of tumor lysis syndrome, when the uric acid crystals can get deposited in the tubule producing an AKI. Muscle-related release of toxins, rhabdomyolysis, can be a way the enzymes in other substance can block the tubules, and it is seen commonly when we are using a drug combination statin with fibrate in a high-risk situation of chronic kidney disease. Thrombotic microangiopathy is one special kind of category of histological type which can be seen with a common drug like CNI that we use in patients for treating various forms of glomerular disease or in the post-transplant situation. Though this is not an uncommon thing in situation of cancer chemotherapy with various forms of oncological drugs. So the causative agents therefore are hemodynamic impact, ACE inhibitor, angiotensin receptor blocker, NSAID, COX-2 inhibitor, cyclosporine tacrolimus. This is the first category, the common drugs which are listed in the slide, that hemodynamic, a pre-renal factor. if I look at the DIKD by specialty, like if the person is in different specialty and finding a renal dysfunction, how you link the drug to the renal dysfunction. For a general practitioner, the anti-infective drugs, which is like the penicillin group of drugs, cephalosporins, and many other kind of antibiotics, if they find that this following antibiotic, the kidney dysfunction has happened, this is likely to be drug-induced kidney disease, which has to be confirmed by renal biopsy or by drug discontinuation and a follow-up. If it is look at the orthopedic practice or rheumatological practice, the commonest drug which produces DIKD or drug-induced kidney disease is NSAID and bisphosphonates, which are used basically for osteoporosis management. In the cardiac context, the DIKD, that is drug-induced kidney disease, is basically because of radio contrast and maybe the RAS blockade. In the neurologist domain, if you look at the DIKD, common drugs which can lead to kidney dysfunction is the use of mannitol for reducing the cerebral pressure, which can lead to volume depletion with AKI, or IVIG, which can lead to a kind of tubular toxicity because of the high amount of sucrose in the IVIG preparation. GI specific DIKD, the commonest cause listed are the phosphate enema, which can produce a kind of phosphate load, phosphate absorption, producing a kind of uh, oxaluria with AKI, or PPI, that is protein pump inhibitors, now are linked to a possibility of increased risk of chronic kidney disease in high-risk situation. In oncological practice, anti-cancer drugs and immunosuppressive drugs are known to be associated with drug-induced kidney disease. So these are the different areas where nephrologists may be called to uh, look at whether this is drug-induced or disease-related kidney disease. The clinical presentation, therefore, is very broad. It could be an asymptomatic rise of blood urea, nitrogen, and creatinine on a routine checkup post-therapy, or it could be a symptomatic presentation where you are evaluating a patient for malaise, anorexia, vomiting, shortness of breath, or edema, which has happened after therapy, which is a uremic symptom, or person can present with decreased urine output following some therapy and is being evaluated, or a volume overload and hypertension, which on evaluation is found to be associated with kidney dysfunction for the first time. So these may be the ways DIKD or drug-induced kidney disease can come to light. The injury patterns that we talked about could be very subtle injury, where even the biopsies may not be able to show that kind of abnormality. A hemodynamic effect, which where there is no injury, but is only a kind of hemodynamic impact, which reduces GFR like ACE inhibitor, NSAID in the beginning, and if realized, it totally reverses. Or there could be a very overt renal injury, that is, which can be historically proven to be associated with vascular injury, tubular injury, or glomerular injury, or interstitial cell infiltration-related injury, which can lead to specific loss of renal functions in the form of presenting as acute tubular necrosis, or osmotic nephrosis, acute intestinal nephritis, nephrotic syndrome, uh, obstruction with hyperuricemic nephropathy because of tumor lysis syndrome. It could be because it can manifest as nephrogenic diabetes insipidus, that is, the tubules have lost its capacity to absorb water and there's a polyuria, or renal tubular acidosis because of tubular dysfunction. Electrolyte abnormalities in the form of hypokalemia, or even a kind of hyponatremia, and chronic renal failure, or a microangiopathy or vasculitis or cholesterol emboli syndrome following therapies with different kind of drugs in the context of atherosclerotic disease. So this could be a presentation which will be very non-specific, wide spectrum, and one has to link the all kind of factors to make a diagnosis of this disease. So therefore, the DIKD syndromic presentation is AKI, which is could have any kind of histological pattern, and is only detected by change in the serum creatinine and urea with a urine output decline, with or without urine output decline. So the one could be an AKI presentation, other could be a glomerular injury presentation in the form of proteinuria, detected by COE or abnormality and presence of clinical edema. Vasculitis-like presentation where the person presents with MAHA or microangiopathy hemolytic anemia with raised urea and creatinine, like a patient of hemolytic uremic syndrome. or it could be an electrolyte disorder related problems because of tubular dysfunction as hypokalemia, diesel tubular acidosis, or low magnesium. Or it could be an asymptomatic disease not picked up, and later on we try to make it as a CKDU, and it could use the drugs. So presentation could be of any type: AKI, glomerular, vascular, electrolyte, or asymptomatic CKD. The commonest nephrotoxic drugs that an internist is fully aware of is shown in the slide. These is called the internist quartet or nephrotoxic drug, which are NSAIDs, ACE or ARB, aminoglycoside, and iodinated radio contrast. So, and people try to always pick these kind of abnormalities when the person develops a DIKD. So this is already well-known fact, and most of the internists and family physicians are aware of this risk. But one is not aware of the risk of drug interaction related kidney injury. Like for example, when we are giving aminoglycoside with furosemide, there is an increased risk of nephrotoxicity and ototoxicity, particularly in the situation of advanced stage septic shock and liver failure. So the interaction is also important. The person is volume depleted, a person is having a hypokalemia and is getting aminoglycoside, the risk of both nephrotoxicity and ototoxicity increases. So this is an interaction which has to be always remembered when we're trying to prescribe a drug which is potentially nephrotoxic but is required. The commonest drug, therefore, which comes in the category of DIKD or is shown in the slide, it presents acutely. We have listed the drugs as in alphabetical order from A to Z. If drugs which starts with A are aminoglycoside or cyclovir, amphotericin, analgesics. Drugs which starts with C are cisplatin, cholesterol. Cholesterol is important drug which we prescribe these days for resistant bacterial infections, and CNIs. The drugs which is in the category from I to L letter, ifosfamide or lithium. Drugs starting with P is proton pump inhibitor and protease inhibitor, which are usually used in a situation of HIV therapies. S is SNT sulfonamide trimethoprim, which is a common drug which is prescribed in a situation of immunocompromised state, and tenophobia, which is usually a kind of backbone of therapy for HIV. V V is here, that vascular endothelium derived growth factor inhibitor that is commonly used in context of oncological practice for treating various forms of neoplasia, and vancomycin. And we have kept others like mitomycin C in contrast. To remember the points, what are the common drugs which presents acutely in the category A of DIKD. The in a chronic presentation of DIKD, the category A drugs like lithium, cyclosporin, aristolochic acid, which is a Chinese herb nephropathy which was used earlier for treating obesity, and proton pump inhibitor, particularly omeprazole, has been categorized as a category A drug presents with chronic kind of presentation of chronic kidney disease. So that was about the type A drugs or DIKD, which is drug dose related. But type B drugs has a big list, which is idiosyncratic, which could be because of diuretics, antibiotics like cephalosporin, NSAID, and rifampicin, neuropsychiatric drugs, particularly anticonvulsants. All the anticonvulsants I mentioned as potential toxic drugs. One of them is carbamazepine, which is said to have, and even the phenytoin is said to have that kind of idiosyncratic reactions. PPIs, particularly omeprazole, has been more studied to be linked with the chronic kidney disease as well as acute disease. Others like warfarin, carbimazole, allopurinol, ethambutol are also type B drugs where the idiosyncratic reaction presenting as AIN could be a possibility. There are still many drugs which have been reported in literature to produce a kidney injury because of idiosyncratic reaction. So type B category of DIKD has a big list. Every drug is a potential drug which can produce a drug-induced kidney disease. Common examples which are shown in the subsequent slides are NSAID. We know that NSAID can present with DIKD, and presentation could vary from acute tubular necrosis to tubular nephritis to glomerular nephritis, particularly minimal change kind of pattern, nephrotic syndrome, renal papillonecrosis, chronic renal failure, salt and water retention, hypertension, hyperkalemia, hyperrenemia, hyperlestin. So all kinds of spectrum is mentioned which could be associated with NSAID on a long-term basis. And the short-term basis, the only thing that can happen is salt and water retention with hypertension. Antibiotics, there are many antibiotics which have been which were linked to nephrotoxicity. The commonest are penicillin, which is called frequently reported. Cephalosporin, carbapenem, aminoglycoside, rifamycin, glycopeptide, all of them have been reported. Sulfonamide, quinolones, amphotericin, or cyclovir. So some are frequent, some are severe, some are less frequent, and one has to be always clear why we are prescribing a drug to reduce the risk of nephrotoxicity. Pharmacodynamic profile, we look at it, the drugs which are concentration dependent antibiotic, that is less frequent dosing like glycopeptide, aminoglycoside, quinone, azithromycin, will have a kind of lesser risk compared to time dependent antibiotics which are frequent dosing like beta-lactam, monobactam, and carbapenem, where the drug exposure is more frequent. So depending on the frequent and infrequent dosing of the antibiotics, we may get a different kind of risk that is associated with such drug prescription. So therefore, the risk factors for antibiotic, which is the commonest kind of drugs which we prescribe and may be linked to DIKD, is related to patient factor that we listed about the age, sex, and race, pre-existing renal disease, specific comorbid like diabetes, multiple myeloma, or proteinuric patient, sodium limiting states like cirrhosis, heart failure, or a nephrotic syndrome, dehydration or volume depletion or hypokalemia, acidosis, potassium and magnesium depletion, hyperuricemia, sepsis, shock, or renal transplant. These are the risk patient factors which may ultimately contribute to the risk of drug-induced kidney disease. So we need to be looking at these factors to decide what drug and what dose to give. There are certain drug-related factors which are considered to be inherent nephrotoxic potential, like aminoglycoside. Dose-dependent factors, if you give in higher dose, like cholesterol, it could be associated with nephrotoxicity. Duration, frequency, and form of administration. That if you are giving in bolus form, that may have a more toxicity compared to giving it in a prolonged infusion or repeated exposure. Drug interactions, it is also important that the drug in isolation may not be toxic, but when it combined, are closely associated with other kind of factors which are nephrotoxic, it can produce a risk. For example, using radio contrast agent, aminoglycoside, anisette, cisplatin, and ACE, different combination in close proximity may lead to a kind of drug associated kidney injury. So this is just a CT scan to show that there are certain kind of images which is said to be associated more with the analysis of abuse nephropathy. That is the lumpy, bumpy deposit structure. That we find that there is kind of nephrocalcinosis, and the contour of the kidney is having a kind of very abnormal pattern. It's called bumpy renal contours, which is best diagnosed by CT scan. And this kind of histology in a proper context is associated with analgesic abuse nephropathy. We may get papillary this calcification or papillary necrosis associated with analgesic abuse, which can lead to a chronic renal failure. Aminoglycoside is one of the common group of drugs which we understand the mechanism of nephrotoxicity. It is seen to be associated with nephrotoxicity in variable percentage of patients, 7 to 35%, and the potential for nephrotoxicity is lesser with the newer kind of drugs, highest with gentamicin and tobramycin, medium with amikacin, and netlimicin is said to have at least 8.9% toxicity as per the reports. The drugs have to be given in a single dose rather than divided doses to reduce the nephrotoxicity. This is just a histopathological kind of slide to show that in a patient who had a kind of acute tubular necrosis, what we see in this slide is the glomerulus looks normal while the tubules is denuded from the cells. This is kind of tubular necrosis. That tubules are like this tubular lumen is showing so many nucleus, but this tubular lumen is showing no nucleus because this is divided epithelial lining. So that we call acute tubular necrosis. And in the other side, right side, what we see that we see ghost tubules. The tubules are not outlined because, but this tubular lumen is filled with cast, which is clearly seen. So this is a kind of acute cortical necrosis where the tubules have become dead, in contrast to the acute tubular necrosis where the tubules are alive but having a necrosis which is going to recover. So that can be diagnosed only by histology. So this is one of the classical images of the immunoglobulin G, that is IVIG or mannitol related tubular toxicity, where you see in the tubules the vacuoles which are normally not seen, and this vacuolar epithelium is because of sucrose toxicity, etc. That is a part of immunoglobulin. Or even the mannitol will have the similar kind of history of vacuoles within the proximal tubule, which in an appropriate setting is linked to a drug toxicity. Was a patient who had developed acute kidney failure following the use of Voveran, the common drug, the diclofenac sodium that we give. What we see is that outside the tubule, there are a lot of cells are there, which are a kind of mononuclear cells, which led to an acute renal failure because of which is called acute nephritis. Patient was given dialysis and steroid, following which he totally recovered. So this is how the kidney histology may many times make a diagnosis of this drug-induced problem. This is a patient where the renal biopsy showed part of the tubules are totally acellular without any kind of clear-cut details. This is a patient who had a kind of passive cortical necrosis, where the glomerulus as well tubules are having a ghost outline without any clear-cut kind of appearance. It's a patchy cortical necrosis in a post-transplant situation because of high dose of cyclosporine with a drug interaction from Simulate, which is a kind of bacilleximab therapy, which is a interleukin 2 receptor blocker. The same patient, where you see that the whole part of the kidney is not giving a good kind of clear-cut outline. So this is a dead tubule actually, and the glomerulus also showing necrosis. So this was a patient of patchy cortical necrosis, drug-induced problem. Occasionally, drugs can be very common drug. This was a patient who was getting nimesulide for pain relief, and what we found on evaluation of kidney failure, but a part of the glomerulus showing a kind of fibrin deposit-like structure. Uh, it was a kind of blockage of the tubule because of vascular involvement in a patient who has drug-induced hemolytic uremic syndrome. Even this vessel was closely, it was blocked because of fibrin thrombi. So it is a thrombotic microangiopathy presenting as renal failure with the drugs. We are have the of the belief that herbal therapy is safest therapy. Herbs cannot harm; it only cure. That's the concept in the lay public. Natural things are better than the synthetic. That may be a concept which is prevalent even now. And it is believed that herbs were created specifically to cure disease by God, and that's why it is not likely to be harmful. But that may not be the case. Chinese herb nephropathy is a well-studied kind of nephropathy, which presents with uh, which was earlier used for weight loss, which is present with chronic interstitial nephropathy, tubular damage, urethral cancer, and herbs were used basically for weight reduction, but it has gone out of use. Star fruit. We are fond of taking fruit and fruit juices, and star fruit, which is a kind of fruit which is quite popular beverage in Asia and even certain parts of India. It contains lot of oxalate. Karma bola juice is rich in oxalate, and if we take lot of fruit juice, this can lead to an acute oxalate nephropathy, which has been reported from Kerala, where this may be a way people enjoy fruit and fruit juices. We know that gadolinium is an important kind of radio contrast agent which is used for MRI. And gadolinium, when you use with the GFR below 30, there is always a risk of extrarenal manifestation in the form of painful feet. That what we see is red feet in a patient who are having a kidney failure, but developed this following an MRI, which was done for seizure in the patient. So this produces a kind of nephrogenic systemic fibrosis. This term looks similar to progressive systemic sclerosis, but it's not the case. It is nephrogenic, means it is related to kidney disease, and the systemic fibrosis happens because of the accumulation of the contrast in the skin and dermal tissue. It is a debilitating condition and can be prevented by not using the drug or after the exposure of the gadolinium, at least 3 to 4 uh, dialysis to remove the gadolinium is advocated. It may not be a common kind of problem, but it has been reported in patients who are having a kidney failure where we are using this kind of agent for MRI with contrast. So it is said that you should try to avoid this contrast agent MRI with contrast, which is a common kind of prescription in neurological practice, particularly in patients who are going to need dialysis. And it is said that if you have no choice, then at least three to four sessions of dialysis will be done routine without uh, looking at the kidney function or urea creatinine to remove the gadolinium. There is no effective therapy at the moment available for such kind of complication and nephrogenic systemic fibrosis, and hence it has to be prevented. Gabapentin we find is a very common drug which is given thinking that it's a safe drug to be prescribed in a patient for relieving the pain of neuropathy or the back pain. And if it is not used with proper dose modification, this can produce a lot of morbidity in the form of somnolence, and patient can become totally unconscious and can get evaluated for stroke. It is said that when you're using gabapentin in late stage of kidney disease, we should use the minimum dose of gabapentin of 100 to 150 milligrams, slowly up titrate the dose if required for treating pruritus or pain. Lipid-loading drugs like statins and fibrates, though are safe drugs, they require dose modification in presence of renal failure, and the drugs should not be combined in the chronic kidney disease because they increase risk of rhabdomyolysis. PPI is a drug which is primarily prescribed by all the physicians and for various non-specific regions throughout the world. This has been linked to acute interstitial nephritis and even the long-term chronic interstitial nephritis. Less is known about its association with PPI and chronic kidney disease, but now it will be realized that this could be a possibility. Proton pump inhibitors usually associated with 20 to 50% higher risk of incident chronic kidney disease in the various literature. In one of the studies, the proton pump inhibitor, when they analyzed in this addict trial associated risk in community in 10,000 patients, they found that the people who have received this drug on a regular basis, they were having a higher risk as shown in the next slide. In this study, they found that if all the factors are taken into account, the use of PPI was associated with increased risk of chronic kidney disease compared to H2 receptor blocker. And hence, this has become less commonly prescribed in a patient of chronic kidney disease and acute kidney disease on long-term basis. In one of the analysis from the Ginger Health System analysis, PPI was associated with secret all analysis, including time varying new user design. So there were various statistical models to look at whether this is a cause or not, and it was mentioned that twice a daily PPI that is using say pantoprazole 2 times a day by associated more risk compared to use the drug being used once daily, and hence that should also be understood and remembered when you're using the drug. Use it for not more than 2 weeks and use it for once a day if required in CKD patient. So in the addict study where the PPI was looked at, they concluded that proton pump inhibitor use is associated with higher risk of incident chronic kidney disease, but they ultimately concluded one more point that there is a future research required to understand what is used and what is to be done for using PPI, which is a very effective drug. The last part of my talk, the newer therapies which are now potentially turning out to be more nephrotoxic, either because of type A type of interaction, is a drug dose dependent, or type B interaction, which is a kind of idiosyncratic reaction. So one of the drugs which has changed the whole kind of management of oncological practice is immune checkpoint inhibitors. The immune checkpoint inhibitor is considered to be a novel therapy of immunotherapy which targets the lymphocyte receptors or their ligands. Because immune-related adverse event can be due to immune hyperactivation. So once you are trying to treat with this kind of checkpoint inhibitor, there could be a kind of immune dysregulation. It can lead to an acute kidney injury of different types like AIN, ETN, and glomerular injury. These immune checkpoint inhibitors are acting at the level of receptor like CTLA4, that is cytotoxic lymphocyte associated antigen, or on the receptor like PD1 or PDL1, that is programmed cell death or programmed death receptors. And by acting at these receptors, they try to take care of the targets of oncological cells, but they by this kind of interaction can produce a kidney injury, which can manifest as an AKI or a proteinuria, which could be a glomerular injury, or a hematuria, or a hemolytic uremic syndrome, which is presented again as a AKI only. term it has been reported that at least 5% of people in the earlier studies who were getting checkpoint inhibitors had this kind of kidney injury. But it is still higher in the recent report because it is being used in combination in this immune checkpoint inhibitors. That when you're using two drugs of different categories, the chances of AKI increases more. Another important therapy is CAR therapy, that is a kind of chimeric antigen receptor T cell therapy, where we try to engineer the T cell in the body, outside the body, and try to infuse it to kill the tumor cells. That is called CAR therapy, chimeric antigen receptor T cell based therapies, which try to eliminate the cancer cell by the immune mechanism. And because of this immune reaction, a lot of cytokine gets released, which can produce a kind of injury which could be of various types, the commonest being the ETN, ETIN or pre state, but all kinds of injuries are mentioned with this CAR therapy, which is an evolving therapy for various forms of oncological management. Anti-VEGF therapy, which is again a kind of very important area of interest in oncological practice, which produces kidney injury because it manifests as accelerated hypertension, proteinuria, acute liver interstitial nephritis, or ETN, or TMA, or the thrombotic microangiopathy. Many drugs are there which are associated with this targeted therapy in the oncological practice, which is targeting the VEGF factor. Several drugs interfere with tubular transport which are being prescribed in the oncological practice, and which can lead to a spurious rise of creatinine, which is called pseudo AKI, because many drugs are transported by the same transport as the creatinine is there, and can give a spurious kind of rise of the creatinine. So, which has to be also understood. So, three important categories of oncological drugs: anti-VEGF, CAR therapy, and targeted checkpoint inhibitors can present with AKI, which is of recent type of AKI that we are seeing in the recent day therapy of oncological management. So when we try to end our talk about how we should look at this drug interaction with and kidney, the 6 R's are referred in the literature, which means first is that drug nephrotoxicity should be recognized. We should look at the risk factors which can be addressed with the proper drug interaction. We should respond quickly. That is, we need to look at it and try to act according to the presence or absence of it. We may require a renal support. That is, person who develops marked uremia has to be treated with dialysis temporarily. We have to rehabilitate the patient because the patient may have a kind of chronic problem which may require a long-term solution. And in this regard, the 6th R is the research, that what are the drugs, new drugs which are being used, what is the risk, etc., and what are the kind of risk profile which should be addressed or analyzed or picked up on time. So, finally, how do you recognize the problem of kidney disease in the context of drug-induced kidney disease? Is urine examination to look for proteinuria, pyuria, which is usually sterile pyuria, and hematuria, microscopic or macroscopic, associated with looking at the CVP and platelet to see that is any anemia or thrombocytopenia, which could be drug effect. Renal functions, particularly we look at the urea creatinine, and if GFR can be calculated with the stable creatinine, once we look at the eGFR. Uric acid, look at hyperuricemia, which could be associated with kidney damage. Electrolyte hypo and hyperkalemia, which is a risk factor for potential nephrotoxicity with many drugs. And ABG to look at acidosis, which may have to be treated. Using an ultrasound to look at is there any chance, is there any hydronephrosis or obstruction, or CT abdomen to look at the morphology or the lumpy kind of bumpy deposits which we see many times in kidney analysis of abuse nephropathy. We may use a biomarker to pick up the kidney disease early, the TIMP2 or insulin-like growth factor B57. But one has to understand that these are the usual things that we do in many situations. But common sense has to be always added to the list of checking checklist to get to the recognition of such problem in a high risk situation. So, who is at risk of this drug induced kidney disease? It is said that old age use of ACE ARB in high dose in predisposed like diabetics, more advanced CKD, and when you are using polypharmacy, where the chances these are the risk factors for developing adverse drug reaction, and it is estimated that 50% of patients develop some drug related adverse effect when the GFR is below 60. And so people who are having chronic kidney disease are higher risk of DIKD, and that has to be always remembered. So to prevent this thing, we should choose the right drug, modify the drug dose with the risk factor, avoid drugs which are high risk kind of drugs like aminoglycosides or NSAIDs in a situation of hepatic disease or a chronic kidney disease. We have to use the alternatives. We have to attend the high risk situation with appropriate interventions like treating hypovolemia, hypokalemia when you are using ACE inhibitor, ARBs, or using aminoglycoside in this situation. Not to copy the prescription of the other specialists, but to familiarize self with the drug prescription to get the right drug, the right patient. So treatment of DIKD is therefore drug reduction and stoppage if possible. You may require immunosuppression in case of allergic response is there that like we give in many kinds of acute insulin nephritis associated with drugs like drugs associated with immune checkpoint inhibitors. Plasmapheresis may be required in people who develop immunity syndrome, and dialysis may be required in those who develop a kind of advanced kidney disease with uremia with drugs. It may not be a common situation but can happen. The two clinical pulse, therefore, is that when you're trying to use the drug, use few drugs and get to know them well. Know the patient's adrenal status before prescribing the drug. And normal plasma creatinine may not be enough. You need to calculate the GFR. Decide the dose by creatinine clearance or eGFR. Be careful in prescribing elderly with multiple drugs. Do not prescribe the drug and go away for others to monitor. Monitor yourself and depend on the drug level monitoring in case of need for those drugs which are nephrotoxic if the drug is available. For example, using CNIs or tacrolimus or cyclosporin in the context of renal transplant. Whenever one is in doubt, you should not hesitate to look up for dosing adjustment in the books or the apps and look at the potential drug interaction which can make the drug more riskier. Take home, consider all medicines as potentially nephrotoxic. Only use required medicines. Different medicines have different patterns of renal toxicity. Vulnerable kidney manifests the greatest nephrotoxicity. By term vulnerable kidney, you mean patients who have chronic kidney disease. Most kidney will tolerate some level of dysfunction. Most syndromes are usually reversible if it is picked up on time. Always get a clear medicinal history from patients in renal failure, including over-the-counter medications, which may not be available in the prescription list of the patient which he has brought. So, to end, what constitutes happiness is a matter of dispute. Some say one thing and some another will say another thing. Indeed, very often the same man says different things at different times. When a person falls sick, he thinks health is happiness, but when he is poor, he thinks wealth is happiness. For me, at the moment, happiness is talking to you people. Thank you. If you are not willing to learn, no one can help. But if you are determined to learn, no one can stop. And that is the motto of my presentation. Thank you.
Thank you so much, sir, for giving your valuable time and sharing your knowledge with us and making this session informative one, sir. I definitely think this session knowledge is going to help all the participants who have joined this session. Sir, we can see, sir, I have received some question from the participant. If you allow, can I take this question with all your permission?
Sure.
So the question is, sir, how to get the diagnosis and the assessment that a person kidney is suffering? Like, what are the examination to be done to assess the damage of the kidney by Dr. Agarwal?
Uh, the, the diagnosis of kidney disease is made by three things. One is the urine examination to look at the presence of albuminuria or proteinuria, hematuria, and cast. Other thing, the blood report that we check usually is a urea, creatinine, and electrolytes. And third thing is that in case anything is found abnormal in this preliminary screening, an ultrasound of the kidney. So, which will show either kidneys are normal or small, or it is showing a kind of swelling, which is called hydronephrosis. So these are the three tests which has to be combined in a situation of suspected kidney disease to make a diagnosis.
And sir, other question is sir from Dr. Singhania, and he's asking when does the that is GFR in children reach adult levels? Like how to access these things?
Uh, I'm not sure about what is the exact age at which the adult GFR is reached, but by definition, adult means when we talk about the age above 18. So most of the children after the age of maybe 6 years or so, they are having a GFR almost close to adult. But I'm not exactly 100% sure that at what age the GFR of adult is same as children.
Sir, what are the most medication which is prescribed by the doctor, sir? What's your suggestion on that? What should be prescribed in the initial stages?
For this drug-induced kidney disease you're talking about.
Exactly, sir. Drugs induced kidney disease.
Whenever you see a patient who has developed kidney disease following a drug, first thing is to stop the drugs. That is the first thing. Most of the time, it gets better once you stop the drug. But one has to realize that the drug is producing a kidney injury. And then, if the kidneys are not improving the way it should, then a kidney biopsy may be required to decide whether to give steroid or not. So, the second step is that those who do not show improvement within a short time, they may require a kidney biopsy after proper evaluation that they're fit for that. And then steroid therapy in the form of prednisone could be used. There is no other approach. If the person had developed a kidney failure which requires dialysis, then dialysis has to be done. And many times we may even need to do a plasmapheresis, which is in very small subset of patients who are having a different type of disease, which is called TMA, thrombotic microangiopathy with the hemolytic uremic syndrome like presentation. So for most patients, only drug stoppage. For some patient, a kidney biopsy to start steroid, and some other patient you may require even dialysis and plasmapheresis.
Okay, thank you so much, sir, for answering all the questions, sir. As I can see, there is no more question from the participant end. I hope that their doubts related to this topic has been cleared, sir. But there is one feedback from Dr. Ayushi. She has written very well presented. Thanks for the session. I
Thank
hope
you.
she has enjoyed this session, sir. As there is no more questions, sir, with your permission, shall we conclude this session?
Yes, thank you.
Thank you so much, sir. And till then, take care of yourself, sir. Hope to see you again with different topics, sir. Have a great day, sir.
Sure. Thank you.